Would you like me to go ahead and share?
All right, not just yet. I'm just going to kick it off for a moment first. Good afternoon, everyone, and welcome to another episode of Ewing's U. Thank you so much. I am Maggie Spada. I'm one of the co-founders of the Little Warrior Foundation and mom to 11-year-old little warrior Lucy. Today, we are thrilled to be hearing from Dr. Erin Murphy. Erin Murphy is an associate professor in the Department of Radiation Oncology at the Cleveland Clinic. She completed residency at the Cleveland Clinic and a subsequent fellowship in pediatric radiation oncology at St. Jude Children's Research Hospital. She specializes in radiotherapy and radiosurgery for brain tumors and pediatric solid tumors, and travels internationally to share her expertise in radiation oncology conferences everywhere, specifically the use of SBRT for pediatric patients, which we'll be hearing a lot more about today. In her spare time, Dr. Murphy is also a marathon runner and a wife and mom to 3 little girls who keep her very busy. Before we kick it over to Dr. Murphy, I just wanted to let everybody know and remind you all that Ewing's U webinar and podcast is a production of the Little Warrior Foundation. We are a national childhood cancer foundation with a laser focus on finding a permanent and complete cure for Ewing sarcoma. We were founded in April of 2020 and have granted out $1 million in high potential therapies for increasing survivorship and decreasing toxicity. We very much so rely on the support of the communities of the big and little warriors who are joining us on this call and across the country. So we really appreciate all of your community support to continue our mission so that we can bulldoze to a solution and continue this vital work. Piero, did you want to say a little bit of housekeeping on the chat and questions?
Yep. Hi, everybody. Thanks for being here. And thanks for Dr. Murphy for presenting today. I am Piero Spada, one of the co-founders as well from the Little Warrior Foundation, also warrior dad to Lucy. And I'm going to be one of your moderators today. And with that, we have a couple housekeeping items. Number one, the format's going to be pretty straightforward. It'll be roughly 30 to 40 minutes of presentation, followed by 15 to 20 minutes of a Q&A session. For your questions, simply go to the right-hand corner of your Zoom screen and use the Q&A box and simply type those in. And then last but not least, just a reminder, we can't answer any personal questions, so no patient-specific questions, please. And with that, I'm going to kick it over to Emily before we get on with today's presentation. Thank you.
Great, thanks, Piero. I just wanted to let everyone know that this session is being recorded, and we will make the recording available as well as the transcription on our website within 1 week. So littlewarriors.org, and from there you'll find the Ewing's U transcripts as well as previous episodes. We're going to begin. We're working on our fall programming currently for Ewing's U. So if you have any topics that you are eager to hear about, or for any of the researchers joining us, anything that you're eager to share with the Ewing's community, we'd love to hear it. So feel free to drop us a note in the chat functionality or email us at info@littlewarrior.org, and we can see if we can get your topics included into our fall programming. That is it from me. So I'm going to turn it over to Dr. Murphy.
Thanks so much. Hi, everybody. I am delighted to be here. I am a proud supporter of the Little Warrior Foundation and grateful to be here today and kind of share with you about this topic that I'm passionate about. So using SBRT and radiosurgery for Ewing sarcoma. I'm a firm believer that it's an awesome tool and it's underutilized in this patient population. I'm finding the more I give talks about SBRT for sarcoma that not many people are using this awesome tool. So one of my goals is to get the word out there about this and share important indications, because I think it's an awesome tool which I'll share with you more about. I also think all of us together can really help keep the momentum going forward that the Little Warrior Foundation has started. So I have no disclosures. And so I think that the benefits of these tools are huge for our younger patients. So both radiosurgery and SBRT are kind of just different names to call the same thing. So it's very focused high dose radiation that we can use to aim at and ablate tumors right where they're sitting. So although you hear the terms of radiosurgery or sometimes gamma knife, it's not a surgical procedure. These are non-invasive techniques to kind of ablate or kill tumors right where they're sitting. So some of the several benefits are the fact that it can be given over a 1 to 5 day procedure, which certainly reduces anesthesia needs for our smaller patients or our patients that may have more claustrophobia or more concerns or anxieties when they're getting these kinds of treatments. There's certainly less impact on daily routine and education and a quicker recovery. So again, these tools utilize multiple intersecting beams of radiation to deliver this high dose focused radiation to a very discrete volume. This results in sparing normal tissue with a sharp dose fall off, which we know can be even more important for our younger patients that are still growing and developing. And by getting in this focused high dose radiation, we're actually able to increase the biologic effectiveness of the radiation dose because we're getting it in a short period of treatments rather than treatments every day, Monday through Friday for 6 weeks. The indications are many, so include unresectable disease, localized recurrent disease, oligometastatic disease, or kind of limited metastases. And what's unique to our younger patients and unique to sarcoma patients is that we also use these tools to consolidate all sites of metastatic disease. So this is very different than the paradigm in adult cancers where you're very limited in the metastases that you treat. Whereas for folks with metastatic Ewing sarcoma in particular, you want to aggressively treat all their sites of metastatic disease, even when they've already responded to chemotherapy. And using these high dose focused radiation tools is a really way to get after that. The last line here is that there's extensive availability and clinical experience, but it's mostly in our older patient populations. So again, the indications for using these tools in our younger patients just in general can be used for both brain tumors and non-brain tumors. In brain tumors, we more commonly use the term SRS or radiosurgery, whereas for outside the brain, we use the SBRT or stereotactic body radiation therapy. So again, essentially the same thing where you're using tight immobilization for the treatment, high definition imaging, high dose focused radiation beams to kill tumors or ablate them right where they're sitting. In the world of sarcoma, the most common indications include treating metastases to the spine, treating metastases to the bone outside of the spine, and treating metastases to the lung. So as a brief background, there's certainly limited SBRT data for sarcoma. However, we know that we really need high biologic effective doses of radiation to control sarcoma, because in general, sarcomas are thought of to be more radio-resistant tumors. We also know that patients with limited metastases to lung and bone are considered curable with aggressive local therapies. However, if you don't treat these metastases, they can usually be fatal. Some of this early data comes from these series that looked at the role of metastatectomy, which essentially which means surgically removing lung metastases. So these come from huge series. This series in particular was looking at both osteosarcoma and soft tissue sarcoma. And you can see that if you remove their lung metastases, that folks are living out 10 years plus, right? So we still need to do better, but it just really suggests that if you're aggressive with metastatic disease, you can improve survival. And then we look specifically at the role of treating metastases in Ewing's sarcomas. I love this series, so it came from the European Ewing's collaborative analysis. And this series looked specifically at 120 patients with metastatic Ewing's. They had to have metastases other than lung only. We know that folks who have lung only metastases have even better outcomes. And so these folks had to have, other metastases besides just lung. and they looked at the role of local treatment. So here, local treatment could have either be surgery or radiation therapy. And since this was an older study, certainly the role of radiation was more like standard fractionated radiation, where you're giving it every day, Monday through Friday for several weeks. And when they looked at local treatment and the impact on 3-year event-free survival, meaning the ability to stop tumors from progressing, if they did no local treatment, meaning no surgery, no radiation, 3-year event-free survival was 14%. If you used a local tool to either the primary or the metastases, 3-year event-free survival was essentially double. However, if you used a local tool to both the primary and the metastases, the 3-year event-free survival essentially doubles. So this really suggests that you need to be aggressive in looking after folks who have metastatic disease by using these local tools. And certainly because SBRT is a local tool, can have significant impact in outcomes in patients with unresectable or metastatic disease. So the initial experience of using SBRT for Ewing's and osteosarcoma came from the Mayo Clinic and was published in 2014. So you'll see here a lot of the data kind of combines Ewing's and osteosarcoma, so it's hard to separate some of this out front, and certainly calls for us to get a better understanding of histology and disease-specific SBRT, right? Because we know these are very different entities that are treated in different ways, but the data so far still combines these two. So this series included 14 patients with 27 lesions, including both Ewing's or osteosarcoma. The median age of patients treated was 24. The median radiation dose is 40 gray, but you can see quite a range. So 30 to 60 gray over 1 to 10 treatments or fractions is what we call them. This just shows that they were trying to be thoughtful. So they're using a reduction in dose for younger patients or for those getting concurrent therapies, which is really important, and we'll talk more about that. This just shows that this is one example. This was a young kid with actually an osteosarcoma metastases to the sacrum. You can see here outlined right here in the left sacrum. And then you can see what their radiation dose lines looked like. So this was actually 5,000, so a really high dose right there. And the normal structures that are important, this is what always limits us as radiation oncologists. So we get, again, in super high doses to these tumors, but we have to be thoughtful about the normal tissues. So we know that the cauda equina, the kind of and the bottom of the spinal cord and the nerve roots that sit right in this area, saw a pretty high dose. Unfortunately, we need to get a better understanding and better follow-up in these patients to understand the impact of these tools on normal tissues, right? Because we don't want to cause morbidity from our treatments either. And unfortunately, this is an early series, and this patient, they did not have follow-up on. So this is kind of the outcomes that they were able to publish. So they had 2-year follow-up, which is pretty good. They said local control for definitive lesions was 85%. That means that they were able to stop 85% of these tumors from growing by using this treatment tool. They say definitive lesions, they treated both lesions with palliative intent, meaning just for symptom improvement, and for definitive intent to try to go for cure. I actually really find that it's hard to differentiate these two in my practice. So I think my intent when I'm using these locally aggressive tools is durable local control. And it makes a lot of sense in folks that are doing well that you want to be aggressive with these tools. And so durable local control is the intent that I think makes the most sense. The 2 failures were in folks who had osteosarcoma lesions treated with a 30 gray and 3 fraction dose regimen. They saw very acceptable acute toxicity, so just grade 2 toxicity. Toxicities are graded on a 1 to 5 scale, and so grade 2 is usually managed very conservatively. However, they did see significant late toxicity in 3 patients. And again, this is great that they shared with us their early series, right? So that we could all learn from this, right? So it's nothing against that they had these outcomes, right? Someone has, at some point, you have to take some kind of a risk and try these tools, right? And so this was early on experience. And so one patient had a grade 3 sacral plexopathy, meaning they had impact on their nerve roots when they received pretty significant dose of 60 Gray and 10 fractions sometime after receiving their initial upfront conventional radiation. So for us as radiation oncologists, we always have to think about how much dose this area had received before and what's the time interval from the prior radiation, because that can really impact what you can get in safely. Another patient had a grade 3 myonecrosis, which means almost kind of dead muscle tissue. You can see that example is down here. So they treated this right iliac metastasis. You can see right here, this orange shaded color correlates with this orange right here. And that's the 5,000 centigrade that was given in just 5 treatments. It was given with concurrent gemcitabine, which we know can be a radiation sensitizer. And also, which is great, right? It might make the radiation more powerful, but it also can have some more impact on the normal tissues. You can see in their follow-up. So this is the muscle tissue all around that bone area that was treated with significant inflammation. And then they also had a grade 3 avascular necrosis of the femoral head, which is the top of the hip, that then went on to fracture in the patient who had a significant dose as well. Again, lots to learn from this early experience. There have been now prospective sarcoma trials incorporating SBRT into their regimens. One of the early ones was a children's oncology group study, which was investigating the role of an IGF-1 receptor antibody. So patients were randomized to receive that antibody or not. And these patients, this has been close to accrual, not published yet. These patients, as part of their treatment paradigm, received 40 Gray in 5 fractions to all bony metastatic sites that were less than 5 centimeters on initial studies. So folks can present with widespread metastases sometimes, right? So this can be a number of lesions that then you're going to want to consolidate or add radiation to try to stop those areas from coming back. And this dose right here, so this 40 Gray in 5 fractions, I highlighted it, right? Because this just came from that series of 14 patients from the Mayo Clinic, and that was just their median dose. So it was a good, good dose to start off with. But again, this is the dose already being used on prospective studies. So I think us as a group of radiation oncologists need to come up with, figure out, is this the right dose or not, right? You can see here, so how they did their target dosing, and they did a little bit of higher dose to where they could see the tumor, and then a little bit lower dose in area there to treat any microscopic disease. The other prospective trial that incorporated SBRT was a phase 2 trial of SBRT for sarcoma bony metastatic sites done by these 3 institutions. So they were not including patients with rhabdomyosarcoma, and they're including patients older than 3 and less than 40. These patients had to have limited metastases, so just 1 to 5 sites of spine or non-spine bone metastases, and they had size cutoffs as well. For these folks, they held the chemotherapy for 2 weeks. The dose that they used for all these sites was, again, 40 Gray in 5 fractions. And this data has been published. So this was their early results. So 14 patients, 37 lesions, but all treated in the same way, right? So they all got the 40 Gray in 5 fractions. So after a median follow-up of about 7 months, the progression-free survival was 6 months, which states, for the median time that they did not progress was about half of a year. When they looked at local control, so they looked at local control by both the patient and by the lesion, since there was more lesions, the local control was quite awesome. So 89% by patient, 95% by lesion treated. They also found this significant and I think important finding, although this data is early, it again suggests the importance of treating all metastatic sites. So when they say consolidation of metastatic sites, that means 8 patients had all of their sites treated with SBRT and 6 of them did not. And here you can see a significant difference to progression-free survival, so 9 versus about 4 months, and even an impact on overall survival for these patients. They reported very reasonable toxicity as well. So 2 patients experienced grade 3 toxicity. One had osteonecrosis that went on to fracture, and then 1 patient had esophagitis during treatment that then was treated. So this is some other published data. So this was a phase 2 study, which was essentially a review combined from the UCSF and St. Jude experience. So this included a total of 55 patients and 107 patients that were treated. You can see, so they in general were treating just all metastatic solid tumors, but in this box, you can see here that the majority of patients that they treated with SBRT were sarcoma patients. The majority of them had recurrent disease, and the majority had multiple metastatic sites. And I highlighted this box here again. They kind of divided the intent, but I think that this is hard to do, I feel like, in a clinical scenario. So what it means is if you're treating them just for symptom improvement, you may not be as aggressive with the dose. And that's what they might be calling the palliative treatments versus the definitive. You can see here they used a wide range of SBRT regimens. These patients were not treated with the same regimens. So they received 25 to 40 gray over those 5 sessions. And for when patients had larger lesions, they divided up the dose a little bit more. So it was 40 gray over 8 sessions altogether. Just when things are bigger, you want to be a little bit more thoughtful about the surrounding normal tissue. So sometimes you might divide it out more. And these are the results so far. So you can see probably about median progression-free survival was about 6 months as well. What was interesting is they did a deep dive into looking at radiographic response and then pattern of failure. So I think we could learn a lot from this. So when they looked at the radiographic response by a special RECIST criteria, the rate of a good response, so whether it was stable disease or up to a complete response, when you're treating lesions in the bone, it's better than when you're treating lesions in the soft tissue. So you can see here 91 versus 77%. And the duration of the response in the bone was longer than for soft tissue disease. And we can see this in our own series and across other tumor sites, right? So with in the bone, it may be easier to kind of delineate and easier to be generous with your clinical target volume when you're including microscopic disease. Whereas in the soft tissue, it might be harder to see, and you may need to add more of a margin for microscopic disease. Or it might be, because it's soft tissue adjacent to the bone, it might be pressing in closer to normal structures, right? So there can be many kind of reasons that might go into the fact to why we're not seeing responses as good in soft tissue targets. They also looked at symptom response, and you can see that 2/3 of patients who presented with symptoms improved with a duration of about 4 months. They had no significant acute toxicity. They did have 2 late grade 3 toxicities. Again, we're seeing that if you're treating weight-bearing bones like the radius or the femoral head, you may see a higher risk of necrosis and then perhaps fracture. And then there was 1 patient who had pneumonitis. I was actually really interested in looking at our series to see what was the rate of fracture in folks with weight-bearing bones. So we presented this probably at 2 Astros ago, and we looked at patients who had SBRT to weight-bearing bones of both the upper and lower extremities. And we saw no increased risk of fracture, which is great. And that was already pretty at like 2-year follow-up. So it's nice to see that. It's hard to say, what may make some patients at higher risk for fracture versus others, but that certainly can be one of the potential downsides of doing this focused high dose radiation. Although we didn't see any in our patients, knocking on wood on my wooden desk right now, but just something important to keep in mind and be thoughtful about. This just demonstrates how they analyze local failure. I think it's helpful information to see. So what you're looking at here is, so the recurrent tumors, so the tumor that had progressed, and this is the 95% isodose line. So essentially what's in green, it was the prior target. So you can see here something that was called directly in field is directly in the field. So you can see the entire recurrent lesion within the area that was treated. Something marginal has this range of 20 to 80% of the recurrent lesion within that treated volume. Then something considered out of field has less than 20% of this kind of recurrent lesion was within this prior green field. So just helpful, and across all series, we try to be consistent in our verbiage, right? So that we can compare and contrast our studies and call things in field, marginal, and out of field in a similar manner. So this was how they looked at their kind of pattern of failure. They had 25% local failure at 1 year, which means 75% were controlled. When they looked at pattern of failure, so most of the patients, so half the patients failed right in field. This certainly may speak to, are we not giving enough dose? Should we consider something different as far as concurrent therapies, just to try to get more of an impact from our treatments? And then I thought, what's interesting here is that you can see, so this is the cumulative incidence of local failure. So soft tissue is this lighter gray color, and you can see a significant higher risk of local failure when soft tissue targets are treated as compared to bone targets. I also find this interesting. I think we see the same across our series. For the 13 local failures that were not in field, the majority had paraspinal disease extension, which means they had soft tissue component extension, which I think suggests we need to be a little bit thoughtful about more about the coverage that we're doing for when there's soft tissue extent of disease. And I'll share with you our own experience and kind of what we've learned from it so far. At this point, we've treated over 140 lesions and probably about 50 plus patients using SBRT for folks with sarcoma. I really wanted to try to take advantage of the fact that we've looked after many patients and get a sense of, can we learn anything about SBRT dose or fractionation, and try to see if we can do better, have a better understanding of what dose is really needed. Again, since the dose that we're using comes from a small retrospective series. And so what I did in trying to think about that, the histology of sarcoma in general is quite varied. And so I tried to group our series into those that were more radio sensitive, which includes all kind of small round blue cell sarcomas like Ewing sarcoma, rhabdomyosarcoma, and desmoplastic small round cell tumors. And then those that were radio resistant like osteosarcoma or synovial sarcoma. And at the last time we analyzed this, the follow-up was about 10 months. What I think is important to kind of pull out and discuss here is that the median time from development of recurrence or metastatic disease to actually using SBRT was over a year. I really believe that these tools should be considered earlier in the treatment course. The folks that we're looking after were heavily pre-treated with multiple kind of chemotherapy regimens, multiple prior treatments in general. And so the more folks are treated, the more maybe resistant their disease comes to our treatments. So this is our series starting back several years ago. And so we initially started off more conservative because it's a brand new tool. At this point in time, SBRT had been used commonly in the adult settings to treat bone metastasis to the spine and to treat early stage lung cancer. So this treating non-spine bone metastasis was a very new paradigm several years ago. And so we started off with like a lower dose, trying to make sure we did no harm. And then eventually our comfort level went up as we saw that folks were tolerating this quite well. And so the median dose that we used here was 30 gray in 4 fractions, but again, quite a range. You can see here that the majority of lesions that we treated were within the bone. We did treat a large number of lung metastasis. So again, we were starting out early, so treating these bony metastasis at kind of a general lower dose, 30 gray in 5 fractions. We were already comfortable treating primary lung cancer to this kind of dose level, and treated one liver metastasis. And so when we look at our results, I'll highlight looking at 1-year local control. So 1-year local control was just under 70% when you look at all comers. And again, this was using some patients getting lower doses than we use now, but it really allowed us to ask that question, or the impact of dose. So when we looked, we didn't see any difference for radio sensitive versus radio resistant when we looked across local control in general. Then we performed this receiver operating characteristic curve to determine the optimal biologically effective dose using an alpha beta ratio of 3 gray. So there's various alpha beta ratios that are associated with the sensitivity or resistance of a disease to radiation. So in general, sarcomas are thought of being more resistant, and that's why a lower number, this alpha beta of 3 gray, is used. And we found a significant cutoff. So we found a significant advantage to this biologic effective dose of at least greater than or equal to 95 gray, which essentially was equivalent to at least 35 gray in 5 fractions for a 5-fraction regimen. And again, SBRT and radiosurgery can be given over 1 to 5 sessions in general. So it just could be different doses can be seen in different regimens. But when you look at it, a way to calculate across dose fractionations is this biologic effective dose. So when we looked at 1-year local control using that cutoff, you can see a significant difference, 75% versus 46% ability to stop these tumors from growing. We saw that the split for radiosensitive tumors also had a significant difference. And here, for radio-resistant lesions, the split was not significant, but you can see here there's certainly a trend looking at a benefit to a higher dose versus the lower dose cutoff. Something else really cool that we looked at, I thought, was looking at this neutrophil lymphocyte ratio. So we found that this ratio that can be commonly found from a common CBC was a significant predictor of both survival and local control in the setting of SBRT for lung cancer. So a totally different disease, but we certainly think that SBRT in general can cause a significant kind of inflammatory reaction that the patient's own immune system might recognize, and it might help fight that cancer. So we looked at our patients, and we looked at the simple CBC that was available pre and post SBRT, and at time of progression or last follow-up. And we found several variables were significantly detrimental to survival. So a higher ANC before SBRT, a higher neutrophil to lymphocyte ratio before SBRT, a higher neutrophil lymphocyte ratio after SBRT. And then we also found so that when you look at those who had local progression, you can see that in general, there was an increase in this neutrophil lymphocyte ratio at time of progression as compared to the pre and post SBRT numbers. And so, this is just like fact finding, hypothesis generating. And then, so we've developed a prospective trial now, thanks in part to the funding from the Little Warrior Foundation, where we're going to be looking after patients with SBRT and checking their just basic CBCs, and also doing a deeper dive into other inflammatory markers and immune markers to see how SBRT may impact patients' immune system, and then eventually see if we can incorporate immunotherapies or that kind of thing. So it's really going to help us understand, what would be an ideal timing to perhaps incorporate those immunotherapies, and which patients in particular might have even more of a benefit. So we're really excited about that, and hopefully we'll be enrolling patients soon. I'm gonna skip this because I see the time is already 2:35. This is just our spine experience. I will highlight this here. So this is looking across several retrospective series of doing spine radiosurgery for patients with metastatic sarcoma. So in these series, these patients only had metastasis to the spine. And in general, when you do spine radiosurgery, it's more commonly done in just one treatment. That's why you see kind of different doses here. When you look at local control across all these series that treated a wide variety of sarcoma diagnoses, you can see pretty decent local control, 96%, 76%, 75%, et cetera, except in these two series that we're using a lower dose for their treatment. So it really speaks to how important getting in the right dose is, but doing that safely. So these EQD2s are just another way of kind of looking at the impact of dose. So they're the equivalent dose as if it was given at 2 gray per fraction, looking at different alpha beta ratios. You can see here in general, if you do 16 gray in 1 fraction or 1 treatment, you can see that the equivalent doses are about half what you get if you do 24 gray in a single fraction. Certainly we know if you're doing 24 gray in a single fraction, there can be more toxicity or more side effects. So you have to be very thoughtful about when you're trying to increase the dose for these sarcoma patients to make sure that it's safe. That's why oftentimes we do a fractionated regimen or divide it up over 5 sessions so that we can get in these high doses, but do it more safely, more thoughtfully for the normal tissues. Also, I think what's very useful there, we've now have CTV recommendations for how to do your volumes for non-spine bone metastases, SBRT. And so essentially it's going to be important to, add a margin in the bone of up to 1 centimeter, depending on kind of which high definition imaging you have available. Obviously, if you don't have high definition imaging, you want to be more thoughtful and you might be more generous about the margin that you're incorporating to make sure you're treating microscopic disease as well. Certainly, as we kept hinting at before, that if you have the soft tissue expansion, you're going to be really thoughtful about adding a margin to your treatment volume also to make sure you're getting after microscopic disease. I highlight just 2 examples here. As I said, that when you're doing non-spine bone met SBRT is newer, so you got to be really thoughtful about the normal tissues that you're contouring to make sure that we give that information to our planners to say, all right, here's normal tissues, here's the target, and make sure you can push the dose away from those normal tissues. So just an example, if you're treating someone with an iliac bone metastases, OAR means organs at risk. You want to be really thoughtful about contouring the valve that's close by and contouring the strip of skin too, to really push the dose in and away from those more critical structures. I highlight one other example below. So this is someone with a metastases to a rib. And you have to be really thoughtful. So when a patient is on the table being treated and they're breathing, this target may move. So an ITV is an internal target volume, which essentially incorporates that motion into your target or into your planning. So just we have to be really thoughtful about when we're treating non-spine bone mets, because they can be all over the body. So you got to be really thoughtful about the normal tissues that you're drawing out and pushing the dose away from. So Ewing's SBRT, what lessons have we learned so far? So certainly can be a challenging patient population to look after. A lot of the folks that we see have had multiple prior therapies. So you want to be really thoughtful about that, and their disease may be more resistant. The folks that we look after rarely have limited metastases. But again, I hope you're seeing that there's a significant advantage to consolidate all sites of metastases. So again, this is a very different paradigm than SBRT in adult patients with metastatic cancer. We're certainly seeing that durable local control is possible. We know that SBRT can be well tolerated as long as we're thoughtful about the concurrent therapies that were given and the total cumulative dose if they've seen prior radiation. I think we do not know yet ideal dose or fractionation schemes. I think we're getting a better understanding, but prospective studies are needed. And certainly, I think it's really important to highlight here that a multidisciplinary team is critical to identify appropriate patients and to incorporate these aggressive local treatments into the overall treatment plan. And just a quick thank you to all of my awesome partners. So it really takes a team to be able to deliver these high dose focused radiation treatments appropriately and safely. So I have a lot of radiation oncology partners who are awesome. And then it's really important to highlight the role of like physicists and therapists that are so important to deliver these treatments safely. And then my awesome pediatric oncology team as well. And a special thanks to the Little Warrior Foundation. I'm happy to take any questions.
Thank you for that, Dr. Murphy. I'm sure grateful that we have that recorded, chock full of information.
Yeah.
I was taking notes like crazy, and I'll definitely be looking back at this one for sure. We have several questions here, but I thought first we'd start off with a general question. In your own experience, I think starting, what was it, 2014 at Cleveland Clinic, looking at SBRT for sarcoma patients as a whole, are you able to parcel out which subtypes are better candidates for SBRT, like Ewing's versus osteo? Because sometimes we talk about one being more radiosensitive than another sarcoma type. Is that playing out in SBRT as
I
well?
think it's a great question. I don't think that one benefits more than the other. I think just we have to be very thoughtful when we're applying these tools. I think in particular, we know that for osteosarcoma, radiation isn't even thought about for an upfront treatment, right? So often when I'm seeing younger folks with metastatic osteosarcoma, they've never even met a radiation oncologist before. And those are certainly settings where if someone has limited disease and you're going for cure, you want to be as aggressive as possible with the doses that you're using, right? So you might need to push the dose more for patients who have osteosarcoma, just because we know in general it might be more radio resistant. So it's not that the tool is better for one diagnosis versus the other. You just have to be thoughtful about how you can use the tool for the specific diagnosis.
Okay. And do we understand, I guess this takes us back to more like conventional radiotherapy, IMRT, like why one sarcoma type will respond to radiotherapy and the other wouldn't? Is there like that biological response, like understanding that at all? Is that understood?
So it's not understood well, to be honest with you. And also even within one histology group, there might be a variety of sensitivities to radiation and SBRT as well. You know, these tumors are always trying to outsmart us. And sometimes we don't know why someone might have a much better response than others. And I think that's where we're learning more and more about kind of the molecular makeup of these tumors and how that eventually we can hopefully get to the point where we can be more patient specific with our treatments, right? Right now, I mean, you guys know it well, we apply these same old treatment regimens to everybody, right? And you know, so hopefully that's certainly an area where we need to learn more so that we can be really patient specific, disease specific, but really the ultimate goal of patient specific, right? For our treatments.
All right, thanks for that. I'm going to hand it off to Emily for another question.
All right, thanks, Piero. We can always count on Lance Mosby for some great questions at Ewings U. So he asked, when used for consolidating metastatic disease, can the multiple locations be treated at the same time? So say 4 sites, but each treated for the same 1 to 5 day period? Or do these have to be done in a series over a more extended period?
That is a great question, Lance. So the way I've been looking after folks who need multiple sites treated is I want to be really thoughtful about their time in the clinic. And also though, you got to be thoughtful about time on the treatment table. So when you're doing these treatments, each treatment might take 15 to 30 minutes, right? And so you don't want to keep someone on the treatment table for too long, because that would just be burdensome to the patient, because our tables unfortunately are not comfortable. But I'm able to look after, treat about three lesions. 4 lesions might be pushing it, but treat about 3 lesions at a time. And the way I've looked after folks that I'm consolidating multiple areas is I'll do the planning session for a few sites, get those treatments started, and then do, while they're on treatment for those sites, do a planning session for the next 3 or so sites, so that I can kind of keep it going and get them done in just a few, maybe just a few weeks. Another thing that you can do is you can actually treat like 2 or 3 sites one day and then intersperse treating 2 or 3 different sites the next day, and kind of then treat every other day and get done over 2 weeks, right? So there's multiple ways to kind of think through it, but I've been really, really impressed by my younger patients and their ability to tolerate these treatments and procedures. It's amazing how well they do with it, with really little side effects. And that's why I'm such a big proponent of doing SBRT. When I see these folks who've gone through so much already, and then they're able to get through these treatments, like hop on a table, I see them for their visits, make sure they're doing okay, they got nothing going, no new symptoms or side effects, and just can go about their day. And that's in folks that are treated to multiple areas, right? So that I've been really impressed and really happy to see that these tools are not significantly impacting folks' quality of life, right? So it's nice that they can get these treatments done in just a few sessions and go about their life.
Thanks, Dr. Murphy. The next question, kind of building off of that. So we talked about why SBRT might be good for those that have oligometastatic disease, but what about for those that present with overtly metastatic disease? Like, what is the upper limit in terms of the number of sites that you can treat with SBRT? And then the flip side of that is what do we do for those patients that have overtly metastatic disease? Does SBRT play a role in that treatment at all?
Yeah, so that's a really great question. So, I often feel like we partner with our awesome oncology team who gives us systemic therapies, right? And so when someone has metastatic disease, it's so important that they're getting some kind of therapy that goes throughout their whole body. And then my tools can be a local tool, right? So certainly in all these patients with metastatic disease, the chemotherapy systemic agents are so important. And as far as when someone has widespread disease, so what's really interesting is, that phase 2 SBRT1 trial from multiple institutions that treated all their patients 40 grade and 5 fractions, they did have only, they did limit it to 5 and under. But if we go way back to that initial European Ewings collaborative analysis, and they remember when they were looking at the impact of local treatments, whether it was surgery or radiation therapy, on the event-free survival, and when you treated local treatment to all sites of disease, there was significant advantage to event-free survival. And we're also seeing these overall survival suggestions from more modern data, right? But when you dive deep into the data from that European Ewings collaborative analysis, certainly folks who had just one site of metastatic disease did better than if you had many. But they didn't find a significant difference in the benefit of local treatment for 2 up to 10 metastases, right? So that shows you've got to be aggressive. It sounds like a lot of treatments, but it makes a lot of sense to be aggressive. So you're right, sometimes we can't treat everything because it could just be too burdensome, because you have to be really thoughtful about impact on marrow, impact on normal tissues. And in those settings where you can't treat everything just because of safety, you prioritize the areas that would be at higher risk for growing, or those that may not have responded well to chemotherapy, or those that are in critical areas that if they did grow could cause neurologic deficits. So then you have to go back to, okay, how should we prioritize these lesions? That's a great question.
Okay, next we have a question from one of your colleagues, Dr. Pete. Dr. Anderson asks, would it be possible to use alpha emitters with SBRT to cause double trouble or double strand breaks in metastases?
Great question, Dr. Pete. So, anything can be thoughtfully done if we think about doing something prospective like that. So I think, as you see that we need to do better with with local control if we can't get enough dose. So it's the settings where if we can't get in that at least 35 gray over 5 fractions, that at least that greater than 95 gray biologic effective dose, where we need to do something more. And I actually, so this is where I was thinking a lot with our awesome colleague, Dr. Ilsalon, who does cryotherapy. So I was talking to him recently and want to sit down more with him about, in those sites that we need to be more aggressive with our local impact that are close to normal critical structures. Can we combine our tools where we can be really tight and carve our dose away around critical structures? Perhaps we would use, cryo as a boost within the middle or that kind of thing. So it's really partnering other kind of local tools or other concurrent therapies at the same time. As you know, so we have a unique experience looking at concurrent pazopanib, right? Which we know that these kind of tyrosine kinase inhibitors may cause more toxicity combined with radiation. So you want to be really thoughtful. We've actually looked back at our series and there's a suggestion of the even overall survival advantage if you're using that kind of therapy concurrent with SBRT. So just figuring out the right ways to enhance our tools and do it safely. But I think there's many potential ways to do that.
Thanks for that, Dr. Murphy. The next question kind of dovetails off of the CBC results, the correlates that you presented there. I'm really curious to know too, why would having high ANCs prior to SBRT and conversely high NTLR ratios, which basically says you're having high ANCs and or low lymphocytes, why does that correlate to a worse prognosis and outcome?
Yep. So I think that's a great question. And I think, unfortunately, why I said that was just kind of fact finding and hypothesis generating is that, so that was just retrospective series. And so the timing of collecting that CPC data was anywhere between like 1 week to a couple months before, right? And vice versa afterwards. So it was kind of like peri SBRT, but not done in a prospective setting where we can really understand the impact. And those levels are so impacted by chemotherapy, right? And so certainly we can see that chemotherapy may be impacting those. And so on our trial, we want our folks to be still getting standard of care treatments, and we're not gonna take them off of certain chemotherapy regimens just so that we can understand, well, what is the exact experience of or impact of SBRT on the immune system, because we want it to be a real world experience, right? We're not going to take kids off of their systemic agents while they're getting SBRT because they still need those, right? We're treating them for metastases, and so we're gonna look at it and kind of divide it up into chemotherapies that are more impactful on CBC, that kind of thing. So more myelosuppressive versus less myelosuppressive, and then prospectively collect that information. It's going to be done like a week before, the last day, or within 1 week after, and then in follow-up, so that we can really get a true sense of those levels. So it's hard to say, we can't really correlate. I can't really answer that yet, but one day.
Too many confounding variables at that sounds like at this point in time. Okay.
Yes.
Can I jump in and ask a question?
Yes.
I recently saw this actually on some of the Ewing Sarcoma message boards where a lot of the patient families seek out advice and input. And I think I know what your answer would be, but I think it'd be powerful to have you state it, is when someone has a wonderful response to chemotherapy, let's say they had lung metastases or small metastases elsewhere, bony met, and it responds on imaging nearly to complete remission. Would it be your advice to still approach local control aggressively? Because we often see people saying, they don't really want to go for it. No one wants to do radiation as much as we love you, Dr. Murphy. No one wants to go get radiation. And so I guess what would your messaging be when someone has a great response to frontline chemotherapy?
Yep. So it's a great question. And it's certainly hard in the lungs. So the lung is a different scenario. So for us to do focus high dose SBRT, you need to see something to aim at.
Mm-hmm.
So in the setting of a complete response in the lung, great, that's awesome, right? And those are the folks that we want to keep a close eye on. So where we do lung SBRT is in the setting of folks who had prior whole lung irradiation as their consolidation tool for lung metastases, and they have a local progression. Or I use it in the setting of folks who have not had prior whole lung irradiation, but they've been followed and then they have limited progression in the lungs. Then it makes sense to aim at that. And I don't think it burns a bridge. I think that if it ever became important to get whole lung, you could do it after that as well. So the lung is a separate situation because we need to see something to aim at. We're not going to aim at just a hole in the lung, based on prior imaging. But the bone, soft tissue is very different. So even the prospective study, so it was not a question or randomizing folks with Ewing sarcoma on the COG trial, randomizing them to get SBRT or not. It was more kind of a feasibility, a part of it. So folks are called to get SBRT to all initial sites of metastatic disease that are less than 5 centimeters in size, regardless of response. So you're still getting after it.
Yeah.
You're still getting after it. And we really believe, why it makes sense to target these areas is that might be the areas where they're most likely to fail. So, and it's much easier to get after it up front when there's the least amount of microscopic disease, right? And when they're not having symptoms from that, right? But it's also so important then that if someone has these awesome responses and they're not having symptoms, it's on us to use our tools in a thoughtful manner where we're not going to cause symptoms, right? Because folks are doing great. Why would you want to do something that can cause symptoms, right? So I think that the tool is very important to be used as a consolidative tool, even in the setting of really good responses, if you want to be aggressive with their local issues.
Thank you.
Great. I had one more question come in that I think is important. For patients that are geographically dispersed and do not have access to someone like you, how can a very good local radiation oncologist best leverage your expertise, this research, and the experience of others who may not who have many more sarcoma treatment expertise? So how can local oncologists get involved?
Yep. It can be hard sometimes, but it comes up almost every day. So I've been thinking a lot about this, and I think there's a couple ways do this. So both in a bigger picture and then a one-on-one patient. So in the bigger picture, I want to reach out and get some combined experiences combined with other folks who do more SBRT like we do, to get together, set up some symposium or sit down and talk, whether it's virtually or in person, and combine our data so that we can ask questions. Sometimes, it's hard because it's a lot of retrospective data, but with rare tumors, sometimes that's the best you can do. But I think it's a really important setting to then combine all of our data and ask some of these important questions about toxicity, dose, what's the best concurrent therapy regimen, who's the patients that might benefit best from this, right? So we need to do that on a bigger scale. And in that same setting with folks that have more experience, we need to develop guidelines that we can share with the community about how to target these, what's the indications, what dose to use, what toxicities to be aware of, what normal tissues to contour. So that's on the bigger, that's something that we need to do as a bigger group and have that information available for others that may not be as comfortable about it, right, to use these tools. And then at a patient specific level, so Dr. Pete and I and a bunch of our pediatric oncology colleagues look after a lot of folks who are from out of town. It's important. I actually had a colleague recently reach out who was asked to kind of give a talk about looking after patients from out of the state. Where now they're having more and more restrictions on us, which is really hard when we just want to help folks, right? So there's second opinion programs that are set up that always has a fee. And that might be where we would reach out to like Little Warrior Foundation or other foundations to see if they would support so that folks can have that expertise available to them. But for us, we're just very happy to reach out to their local doctors, kind of talk through what their comfort levels are. The blessing is we actually look after a lot of folks from out of town who actually, so we can meet them and do virtual consults and then bring them here for the treatment planning session to meet them in person and then bring them back for their 1 week of treatment. That's what's also so cool is like, although we don't want to force folks to travel, if these kind of treatments are not locally available, the blessing is it's done in a week. You know, and then we can follow people locally. They don't have to come back. They can send us images and we can have virtual follow-ups. And so we do a lot of that. And that's allowed us to extend our tools to wider reaching fixes.
Great. And I know we are at time, but there was an important plug in the chat box for the National Ewing's Tumor Board, which is an effort that Dr. Trucco, some of your colleagues, and others are spearheading, and something that Little Warrior wants to make sure everyone's aware of. So we'll include some information in the follow-up to this for that tumor board, because that could be a great option for remote folks.
That's awesome.
Thank you so much, Dr. Murphy. There's more questions in here, and I know that we could stay and talk with you forever, but you've got plenty of patients to get back to. Thank you guys all for joining. Dr. Murphy, the information was awesome. On a personal note, we adore you and love you, and thank you for taking such good care of our Little Warrior and so many others that we've come to know in the Ewing sarcoma community. To everyone listening and on the call today, we will see you back again in September. Please be sure to subscribe to our Ewing's U emails. You can do that by going to littlewarrior.org and navigating to the Ewing's U tab on the website. Also follow us on Instagram and Facebook, as we always post about our next coming speaker that way as well. Finally, we have a phrase here at Little Warrior that we feel embodies our fight in honor of and in memory of so many little and big warriors who have faced this cancer. It's how we sign off on all of our communications, both internally and externally. So while I know most of you are muted, the four of us will say it together. It's swords up, Dr. Murphy. Just
I know.
So on a count of three, everyone. 1, 2, 3.
Swords
Swords
up.
up, guys. Thank you so much. We appreciate it. Have a good rest of the day.
Okay.
Bye-bye.
Bye-bye.